Chronic pain is in the brain. Hi, I'm Dr. Krista, co-founder of the American Posture Institute, and today we'll be discussing about how chronic pain is in your brain. Now, if you've ever had a patient who presents to your practice and they tell you, I feel hopeless, I've tried everything and nothing's working. I've been to every other specialist and I can't find the solution. I feel like I'll never be out of pain. If you've ever had patients who present to your practice and tell you these things in a moment of complete disparity, of hopelessness, or maybe they don't say these exact words, but you can see it in their eyes. You can see that they've tried everything to get out of pain, but they've been unsuccessful. They feel hopeless and they're searching for solutions, which is what brought them to your practice. They're hoping that you will provide them with the solution that they need to have a better quality of life. You see, chronic pain is a serious condition that's impacting your patients in a very significant way. Did you know that 1.5 billion people worldwide suffer from chronic pain? 1.5 billion. And that 25.3 million people suffer from pain every day. And that pain costs society at least $560 to $635 billion annually. That's a total amount of $2,000 for everyone living in the United States. You can see from a public health perspective that this is a tremendous impact on our society. We understand that it's affecting us from a public health level, and we've seen it in practice where our patients feel hopeless in search of the solution for their chronic pain problem. So what is chronic pain? Chronic pain is ongoing or recurrent pain lasting beyond the usual course of acute illness or injury, or more than 3 to 6 months, and which adversely affects the individual's well-being. So this is chronic pain. And what I want to address right now is the fact that there's a difference between acute pain and chronic pain. So to fully understand our patients who present with chronic pain, it's important first to make the differentiation between acute and chronic pain. So we'll talk now about what acute pain is, and then we'll go back to chronic pain so that we can provide you with the solutions that you need to help your patients overcome chronic pain patterns. So let's focus on acute pain. Acute pain comes on suddenly and does not last more than 6 months. So it comes on suddenly due to a specific laceration or injury, and it's provoked by that injury and serves a useful biologic purpose. So for example, if you have a painful stimulus or noxious stimulus, there's a biologic purpose that we express acute pain. It's a reminder to our body that we're in a healing process, or it's a reminder to our body if we have a bum ankle, for example, that we need to rest that ankle. And this is associated, acute pain is associated with sympathetic nervous system activation. So we have a stress response, that fight or flight feeling associated with acute pain or injuries. And it's self-limited, meaning that it will heal itself. Now, the therapy of acute pain is aimed at treating the underlying cause and overriding the nociceptive signals. So let's talk more about nociception. When we talk about nociception, I want you guys to identify A delta fibers, C fibers, and the spinothalamic tract. So the A delta fibers are lightly myelinated, and they respond to mechanical and thermal stimuli. They carry rapid, sharp pain and are responsible for the initial reflex responsible for acute pain. Now, what's important to understand about the A delta fibers is that first point there, they're lightly myelinated, meaning that they don't have a lot of myelination, so they're actually a slow fiber. And then we have C fibers, which are unmyelinated, and they have the slowest conduction of carrying neural signals. Activation of C fibers via chemical, mechanical, and thermal stimuli leads to that slow burning pain. So again, with A delta, we have that initial reflexive response to acute pain. It's a sharp, rapid pain. But our C fibers are more of that slow burning pain that we experience over time. Now, the A delta fibers and the C fibers transmit nociception, and then they synapse in the dorsal horn and ascend via the spinothalamic tract. Now, the spinothalamic tract carries pain and temperature, so information associated with a burn, for example, would also be spinothalamic. If you stub your toe, if you have a laceration, if you have an acute injury, this will all be carried and transferred to the cerebrum via the spinothalamic tract. Now, of course, we all know the gate control theory of pain. This is Melzack and Walls back in, I think, the 1960s. Now, what this demonstrates is that there's an inhibitory pain modulation at the spinal cord level. So we have A beta fibers. Remember, with nociception, we talked about A delta and C fibers. Now let's talk about A beta fibers. So with A beta fibers, they're myelinated with fast signal transmission. So our C fibers are unmyelinated, and our A delta fibers are lightly myelinated, meaning they have slow transmission. Now, these A betas are highly myelinated, fast signal transmission, and they're activated by tactile, non-noxious stimuli. Their inhibitory interneurons in the dorsal horn are activated, leading to inhibition of pain signals transmitted via the C fibers. So right there at that spinal cord level is where we have the inhibitory pain modulation, or the gate control theory of pain. Now that we understand acute pain and nociception and the gate theory to control pain, let's talk again about chronic pain and how chronic pain is different from acute pain. So chronic pain may be considered a disease state, and it may arise from psychological states and serve no biologic purpose, and it has no recognizable endpoint. So that's an important point right there. There's no recognizable endpoint, meaning that I don't just heal from the acute injury. I have ongoing, recurrent episodes of chronic pain. Now, the therapy of chronic pain must rely on a multidisciplinary approach and should involve more than one therapeutic modality. This is a really important point because with our acute pain, what we wanted to do was identify the underlying cause of acute pain and override the nociceptive signal. With chronic pain, however, it's demonstrated through the research that we need a multidisciplinary approach that's going to improve their functional capabilities, but this requires multiple therapeutic modalities. So chronic pain is a very complex, it's a very unique, and it's a recurrent experience, meaning that different patients have different pain patterns. They have complex issues then leading to chronic pain, and we know that it's recurrent in nature. Now, an important thing to understand about chronic pain is that it's an output signal from your brain. Again, chronic pain is an output signal from your brain. So let's talk more about the pain NeuroMatrix so we can understand that neurology controlling chronic pain. So pain is an output of the brain that's produced whenever the brain concludes that the body tissue is in danger and action is required. Okay, so again, the brain chooses to make an output signal of chronic pain. And the reason it makes that choice to have a pain signal is because the brain concludes that the body tissue is in danger and action is required. So the brain, within the pain NeuroMatrix, says we need an output signal, there's a chance that we may be at risk to the body. And so the brain creates this output signal of chronic pain. Now, pain is a multi-system output that is produced when the pain NeuroMatrix is activated. And when pain becomes chronic, the efficacy of the pain NeuroMatrix is strengthened via nociceptive and non-nociceptive mechanisms. So what that means, and this is an important point because then we can better understand our chronic pain patients' presentations, is that they get to the point where nociceptive as well as non-nociceptive mechanisms signal that pain signal. So that when we become chronic, the efficacy of the pain NeuroMatrix is strengthened via nociceptive and non-nociceptive mechanisms, meaning that our patients can actually experience pain more often. So less input, both nociceptive and non-nociceptive, is required to produce pain. This is where your patients start telling you things like maybe you just you do a normal evaluation and you barely touch the patient and they flinch and they say, oh, that caused a lot of pain. Now that's an exaggerated response, of course. So this is an exaggerated response because less input, nociceptive and non-nociceptive, then produces pain when the condition becomes chronic. So looking more specifically at that neurology, we know that the anterior cingulate cortex is important for chronic pain. So it connects the emotional limbic brain with the cognitive prefrontal cortex, and it establishes an emotional value of your pain. Now, an emotional value of pain is important to the patient, right? Because this is where they take the physical experience of pain and they tie that to an emotion. And it coordinates the selection and planning of an appropriate behavior or motor response strategy. So now we have an emotional value of our pain, and then it connects with the prefrontal cortex to determine our motor plan of how we're going to respond to that chronic pain. Now it's also active in perceived pain and anxiety. So if we look at the fact that it provides emotional value and that it's active in perceived pain and anxiety, it means that you don't even have to experience pain, but it can activate when you think of even being in pain. And this is where patients, when they think about the worst case scenario, they say things to you like, oh, I feel sick to my stomach even thinking about that. Nothing has actually happened. They haven't even had that stimuli. But what happens is that perceived threat, that perceived pain, that perceived risk to the body, because of the anterior cingulate cortex, activates it and creates a pain output. Now, that emotional value of pain is really where your patients are going to express a lot of emotion. So that's where they'll tell you things like, I feel hopeless. We see a lot of catastrophization with chronic pain patients. They think in terms of catastrophes. That's because they've established a high emotional value associated with their chronic pain. Now, it's also very important to discuss the somatosensory cortex. Now, pain output signals are allocated in an anatomical reference in the sensory homunculus. So we all learned about the sensory homunculus in school. You remember those images of the sensory cortex, and then you see a little man who has big lips and big hands and big feet, and it's a representation of our sensory homunculus or our sensory cortex. So within our sensory cortex, we have a representation of a map of our entire body. So you have representation for your hands, for your wrists, for your elbows, for your shoulders. Now what we see within the sensory homunculus is that we have less representation for our midline structures, but we have greater representation for our outer structures such as our hands and our lips and our tongues and our feet. The reason being is these are highly innervated areas. We use them a lot. We use our hands to interact with our environment commonly. You know, we use our tongue for taste. We use our mouth for taste. We utilize our feet to keep us grounded. So these highly innervated areas that we use very often have a greater representation in the sensory homunculus. Now, what we've seen commonly is that our midline structures tend to experience chronic pain more often. And here's the thing that's really important to understand about this is that old pathways of pain are more commonly reactivated than building a new pathway. So it's easier for the brain when it wants to create a chronic pain output signal. Remember, it's an output signal in response to the perceived threat to the body. So we create this output signal, and it's easier for the brain to go back to an old pain pattern than it is to create a new one. This is why your patient's going to come in and say things like, my back's been hurting for the last 20 years, or, oh, I've always had a bum knee, it's been hurting me, for the last 15 years. They have these chronic pain patterns because when your brain creates an output signal of pain, it's easier to go back to a recurrent pain pattern versus creating a new one. Now, what happens in the somatosensory cortex is that we start utilizing less the parts of our body that are in pain. So for example, if you have lower back pain on the right side, then you may change your entire posture positioning around that chronic pain. You may change your gait pattern. A great example of this associated with acute pain is we have a sprained ankle. So what do? We change our entire gait pattern around that ankle because we don't want to put pressure on it, okay? So a less exaggerated example is going to be low back pain that the patient's had for 20 years. Now what happens in the somatosensory cortex is that your brain stops paying attention to the parts of your body that you don't utilize. Okay, so imagine being in a cast. If I'm in a cast because I broke my wrist and I'm in a cast for 6 months and I take the cast off, now we can't expect that we have the same level of muscular activation, and we can't expect that it's going to be easy to just suddenly write our name again the second we have the cast off. We have to relearn these skills because what happened is that you haven't utilized your wrist, you haven't moved it, creating proprioceptive signals to the somatosensory cortex for that representation in a long time. So your brain said, okay, my wrist must not be quite as important as it used to be. So I'm going to give more preference to the fingers and to the elbow, or maybe even to the shoulder. So those areas become strengthened in the somatosensory cortex, whereas this area here has less preference. So we need to retrain it, and the way that we retrain it is through rehabilitation. Now with rehabilitation, we're stimulating proprioception to this area to remind our somatosensory cortex that it's really important that we utilize these joints properly. So what happens with our chronic pain patterns then is that we can have misrepresentation in the cortical maps or the somatosensory cortex. So that when you go through rehabilitation, it's important to recognize that you really need to have emphasis of rehabilitating the areas of chronic pain because it's a pain output signal from the brain, but it can create less representation in the cortical map if we don't have full recovery. So we recognize and we see these relationships in neurology, and it's fascinating, but what's important to understand is that we have plasticity. We have a plastic system, so we can retrain that with our rehabilitation. Now, from a brain-based perspective, if we want to stimulate the sensory cortex, we have 3 treatment strategies. Number 1 is manipulation. Now, manipulation of a joint space is a very powerful therapeutic approach. In fact, when you move the joint space, then you hear that cavitation, for example, and that is going to be a very strong stimulus to the sensory cortex. And then we have movement. Now, movement isn't quite as strong of a sensory input as the manipulation, but movement is a great stimulus to the sensory cortex. And there's 2 types of movement. There's active and passive, meaning that the patient moves themselves, or you can physically move the patient if they're unable to move themselves. For example, a frozen shoulder patient, okay? So we give movement to those joints, which increases proprioception and helps stimulate the brain saying, hey, pay attention here, pay attention here, pay attention here. So as I've intentionally moved these joints, we're bringing awareness to the brain to create greater proprioceptive patterns. And then stimulation. There's a lot of different stimulations that we can utilize. For example, you can utilize functional tape, you can utilize vibration, you can utilize topical gels, you can utilize hot and cold packs. These are all stimulants. So again, our 3 treatment strategies from a brain-based approach, because we're applying a treatment methodology to then stimulate the brain. So we have manipulation, which is going to be the strongest, largest impulse. We have movement, both active and passive. When the patient moves themselves physically, it's going to be more prominent than passive. And then stimulation. There's all kinds of different stimulations that we can provide to the body to help the patient, bring attention to that area and help override that pain experience. Now, pain is a negative factor of neuroplasticity. So this is a really key concept that I really want you guys to get and own. And when you own it, it becomes exciting. It becomes exciting because you understand better the relationship of the neurology and how you can play an active role in helping your patients overcome negative factors of neuroplasticity. So we all know that the brain is changeable, it's plastic, it's dynamic. It's always changing in response to the stimulation that you're feeding it or not feeding it. Now here's the thing, is that our brain craves complexity. It craves complex stimuli. So when you do very complex stimuli, like complex exercises during rehabilitation or complex cognitive activities such as crossword puzzles, the brain really pays attention. Where the brain stops paying attention is when you do very high repetitious, low force activities that you've done over and over and over again. The brain doesn't pay attention to that, but it craves complexity. Now here's the thing with neuroplasticity that we need to understand is that there's positive and negative factors of neuroplasticity. So some examples of positive factors of neuroplasticity is when you're very mindful of what you're doing and you challenge the system to the point of neural fatigue but not beyond, and you challenge the system with high intensity, difficult in the sense that it's complex, so complex exercises. And when you're mindful, so you're actually thinking about what you're doing. Your mind isn't off in space listening to your headphones, you're thinking about what you're doing. And then also a stair-step approach. So we never want to hit plateaus with our patients, meaning that if they came in yesterday and they were able to do 2 repetitions of an exercise, the next day we want them working on 3. And then the day after that, we want them working on 4. So there's always that stair-step. What we don't want to do with our rehabilitation plans is we give them a rehabilitation plan and we say, okay, do this for 6 months. And then we check them again in 6 months. With that, we haven't created any functional goals and we haven't created the stair-step approach where we're constantly monitoring, does the patient get better? Does the patient get better? Does the patient get better? Because if not, they'll get to a point where they'll plateau. And once they hit that plateau, the brain will stop paying attention and it will be a negative impact with our neuroplasticity, okay? So again, for positive factors of neuroplasticity, we want to give them the stair-step approach, we want to be mindful, and we want to do complex rehabilitation. When you set up your treatment plans, I want you to consider these 2 important concepts. The first important concept is that pain is a negative impact on neuroplasticity. And the second component is that when we reduce threat or risk to the body, we reduce the amount of output pain signals from the brain. So we want to focus on getting them out of pain first, and then we want to focus on reducing threat to the body. When we do these 2 things, suddenly the patient's out of pain, and now we're preventing the pain from coming back. Now that's a great solution. So that's where we go from a pain reduction to a postural correction model. So number 1, first priority, get them out of pain. They'll be feeling better, which is a good thing. Plus, now we're not limiting or inhibiting our ability of making neuroplastic changes. So get them out of pain, number 1. Then shift to a postural correction model. We got to do the postural correction because we want to inhibit the amount of threat to the body by reducing postural distortion patterns, because we know that there's so many health effects associated with postural distortion patterns. Now we're setting the body up for success in healthy alignment. So we can reduce the amount of threat to the body, and we know that that's the solution to the prevention of chronic output pain signals. So let's talk about a chronic pain protocol, because I want you guys to be able to take this information and implement it right away in practice. So the first thing that I want you to do, this is a 5-step protocol. The first thing that I want you to do is to determine your treatment. So the patient comes in, you identify their case presentation, and then you're going to decide if you're going to do manipulation, movement, or stimulation. Now, all of these work. It's just a matter of how you apply it, when you apply it to what patient. So you're going to identify, based upon their case presentation, what the best modality of treatment will be for them. And you can always combine these things too. In fact, number 2 is neuroload for complexity. So for example, when you set up your rehabilitation plan, which is full of movement strategies or exercises, neuroload the patient to make it more complex for the brain. So instead of the patient going into the rehab room or doing at-home rehab and just totally zoning out on the rehabilitation that they're doing, we want to bring mindfulness into it, meaning that they're very mindful of each of the joints that are moving and they're constantly paying attention to what they're doing. And maybe we make it multimodal. So for example, while doing squats or while doing any sort of exercise or postural correction exercise, we add electrical stimulation to it. Or maybe they're wearing functional tape. Or maybe they're balancing on one leg while doing VOR activation or while doing eye exercises. By adding that multimodal, it's called neuroloading, which creates more complexity. And we know the brain craves that complexity to make neuroplastic changes. And then number 3 is patient education. So I really want you guys to focus on patient education for our chronic pain patients in particular, because we need to manage their expectations and we need to set rehabilitation goals. So managing the expectations means this, that you want to be honest with them and you want to set them up in a way that you're going to be able to deliver on what it is that they're expecting. And number 2 is rehabilitation goals, because we want to set small wins, that stair-step effect. So we want to go from 2 repetitions to 3 repetitions, 3 repetitions to 4 repetitions, 4 to 5. And so every day they're focused on that specific goal that it is they want to achieve. By focusing on those functional goals, then we can have that stair step so that we prevent that plateau. Because if not, we'll just get here and we won't get better. Every day there's an intention set for a rehabilitation goal. And number 4 is shifting from pain to posture model. So get them out of pain first, and then again, we want to reduce the amount of threat to the body. So reducing the amount of threat to the body, one of the great solutions is to have better posture. Now, to be clear, it's not the only solution. I mean, there are definitely other considerations which you're learning from the other presenters, but it's one solution that you should definitely integrate with your clinical protocols. So you get them out of pain, and then you focus on better alignment with postural correction. And then number 5 is neuroplastic changes the posture system. So when you set up that rehabilitation, again, think about what determines neuroplasticity and continue to add complexity to their rehabilitation so that you can stimulate neuroplastic changes in the posture system. And also, something to consider is that it requires high repetition to create neuroplastic changes. Now, when I say high repetition, it doesn't mean you do 20 reps. It means that you do maybe 3 to 5 repetitions, but you really hold it longer and you do it multiple times throughout the day. Okay? So to be clear, it doesn't mean you do 20 bicep curls without thinking about it. That's not going to create neuroplasticity. What you do is 3 or 5 or maybe even 10, but you're going to do really complex exercises that challenges the brain and the body. You'll do a small amount of repetitions, but then you'll do that 5 times per day. So instead of doing 1 hour-long rehabilitation session, you're going to have the patient do their rehabilitation about 5 times per day. Now, maybe it's only 10 minutes 5 times per day, which is 50 minutes overall, versus doing 1 rehabilitation session that's going to take them an hour, okay? So think repetition. Don't think high repetition per exercise, doing 20 bicep curls. Think, I need my patient doing this multiple times throughout the day to really stimulate the brain, remind the brain how important it is that we achieve these neuroplastic changes. Okay, so again, from our chronic pain protocol perspective, we have 5 steps. Number 1 is determine your treatment modality. Number 2 is to neuroload for complexity, making it multimodal. While they're doing any sort of exercise, have them stand on one leg for one leg balance, have them stand in sharpened Rombergs, or add eye movements with posture exercises, add e-stim, add functional tape, make it multimodal and more complex. Number 3 is patient education. Please manage their expectations and set rehabilitation goals. Number 4 is shift from pain to posture model. So once we get them out of pain, then we got to reduce the amount of threat to the body so that we can reduce the amount of output signals from the brain of pain. So that's where the posture part comes in. And then neuroplastic changes the posture system. So set up your rehabilitation in a way that we're always stimulating neuroplasticity. We want the patient doing these rehabilitation exercises about 5 times per day with high intensity, very mindful, focused on a goal each time they perform that rehabilitation. Remember, I'm going to say it again, that chronic pain is an output signal of the brain. To prevent recurrent chronic pain, we need to reduce risk to the body. That's our goal with chronic pain patients. As the practitioner, when you look at that patient, I want you to think, how can I reduce risk to the body so that we can prevent ongoing expression of chronic pain? And when you do, your patients are going to be coming in saying, I have hope again. I didn't even know this was possible. They'll tell you, it finally worked. I've been to every specialist in town. I've tried everything. And what you did finally worked. They'll look at you and they'll say, I'm pain-free and I'm happy again. Now, when you help your chronic pain patients achieve happiness, achieve the ability of performing activities without pain, you have just provided them a whole new quality of life. You have become the solution. At the American Posture Institute, we live by our core value that your success is our priority. We want to do everything that we can to help you on your educational journey to become the health expert that gets results, that makes a difference, and be the expert that you always dreamt of becoming.